Good afternoon. This oversight hearing for the Subcommittee on Health will now come to order. Before I begin my remarks, I would like to highlight some numbers. First, $20.9 billion. That's the amount the Veterans Health Administration received in 2001 at the onset of the global war on terror. In that same year, an estimated 16 to 17 veterans took their own lives every single day. Second, $121 billion. That's the amount the VHA received in 2024, after nearly 2 decades of war and an entire generation of veterans now relying on the system built to care for them. 17. That's the number of veterans our nation loses to suicide every single day in 2024. That number could be higher, as the VA does not include veterans who lose their lives to overdoses in its official suicide statistics. The numbers tell a clear story. VA's problem is not a lack of resources. VA's problem is not a lack of funding. VA's problem is not a lack of staffing. VA's problem is not that Congress has failed to provide what it needs to care for those who have served. Since the beginning of the global war on terror, VA's budget has increased an incredible 479%. Yet the number of veterans we lose every day has remained approximately the same. And these are just the suicides that we know about or that the VA counts. Some seem to believe that the solution is straightforward. Continue to invest in VA staffing, expand services, grow the system. But the numbers do not lie. If money alone could solve this problem, it would have been solved long ago. No, the VA does not have a resource problem. It has an access and a process problem. It's a blatant failure of the VA to adapt to the needs of the very people it was created to serve. VA's current processes are not designed to provide veterans care when and where they need it. Instead, veterans are left waiting, navigating delays, bureaucratic red tape, and systemic inefficiencies that create barriers rather than breaking them down. While I believe that Congress and the VA has taken some necessary steps to increase access, it's not enough. We continue to hear from veterans who are turned away from the life-saving care that they need. Some are denied residential treatment because they have not previously sought VA care, as if a veteran in crisis should have predicted their need for help years in advance. Others are told they cannot access community care unless a VA facility fails to meet a 20-day threshold, forcing them to wait even when immediate alternative options exist. And some are simply lost in the system, bounced from program to program, expected to navigate a maze of bureaucracy while struggling with the very mental health conditions that make the process overwhelming. In one particular case, a veteran suffering from severe alcohol withdrawal who was seeking admission into a residential rehabilitation treatment program in the community was outright denied because the VA stated they had a bed available 100 miles away. Had the leadership at that community facility not stepped up, the VA would have effectively forced that veteran into homelessness. That's why I support Chairman Bost's Veterans Access Act, which takes long overdue steps towards fixing these issues. The Veterans Access Act recognizes that the goal should be to protect veterans, not VA bureaucracy, and it cuts through VA's arbitrary restrictions by allowing more veterans to seek the care they desperately need in the community when the VA cannot provide it. VA claims that there is no wrong door for veterans seeking care. Yet, we continue to hear about doors locked, doors hidden, and doors that simply do not exist. It's time we stop making excuses and start making changes, real changes that put veterans first. Today, we will hear firsthand from those who can speak to these process failures and those who can help us fix them. The cost of inaction is too high. Thank you all for being here. I look forward to today's discussion. With that, I yield to Ranking Member Brownlee for any opening remarks she may have.
Thank you, Madam Chair. I'd like to first say that we cannot have a hearing discussing veterans' access to mental health care without also acknowledging the very real impacts that the Trump administration's chaotic and haphazard actions are causing both to VA's mental health workforce and to the mental health of many veterans who rely on VA for their health care, their support system, and their livelihoods. Veterans are scared that their VA mental health providers who are being forced to report to work in person at facilities that don't have room for them will decide that providing care in an environment that doesn't ensure veteran privacy isn't worth it and will resign from the VA. They are scared that the very support staff who make it possible for VA providers to focus on care and putting veterans first will be fired, leaving clinicians less able to focus on their care. And they're scared that the outside research and agencies that help improve VA care will be shut down, weakening VA's ability to provide world-class care. Unexpected VA staffing shortages are already affecting veterans in my district. Just last Thursday, I held a roundtable for veterans to share the impacts they're experiencing related to workforce cuts at VA. In a very concerning way, I heard that at a local vet center that serves many of the veterans in my district, there is only one provider left to offer care. Typically, vet centers employ at least 4 or 5 providers. Because of this severe staffing shortage and VA's failure to fill these critical vacancies, the vet center now can only offer group therapy, which is not clinically appropriate for every veteran. Workforce shortages and cuts at VA should not be what determines how and where veterans receive care. If the Trump administration moves forward with its plan to further cut its workforce by up to 83,000 employees, I fear this problem will only get worse and veterans have less choice than ever before. This context leads me to today's hearing topic. The DOGE cuts and the Trump administration's workforce actions are already directly impacting the programs we're discussing today. My staff has heard of at least one researcher who was fired from VA's Center for Substance Addiction Treatment and Education, the center responsible for developing best clinical practices for substance use disorders. The Trump administration has also taken aim at the Department of Health and Human Services, Substance Abuse and Mental Health Services Administration, or SAMHSA, with cuts of up to 50% of the workforce expected. SAMHSA oversees 988, the National Suicide and Crisis Line, which routes calls directly to the Veterans Crisis Line through 988 Press 1. And although SAMHSA's programs do not directly serve veterans, cutting its workforce will undoubtedly have ripple effects across any provider of substance use disorder treatment. I agree with my colleagues across the aisle that we must ensure that any veteran who is ready to seek assistance can get that treatment. But I don't agree that the answer is to cut existing workforce at VA, cut other essential services and research, and just throw the doors open to community providers. Because VA has not developed a fee schedule for residential rehabilitation treatment programs, community providers who treat veterans can effectively set their own rates, and VA will reimburse them at rates far higher than the industry norms. These providers have a vested financial interest in treating veterans, a population that they admit in their own statements that they have not been able to access because so many already receive care at VA. Worse still, there's a serious lack of oversight over community providers. There's no guarantee that veterans receiving care in the community will get better, more timely access to care, and we don't know if they do because VA doesn't track that. When veterans do access care at residential treatment facilities in the community, we have no way of knowing the level of treatment or support they are getting. We don't know if veterans are receiving care from providers who understand what it means to be a veteran and can establish a rapport with their patients. We don't know if they are being referred back to VA care in a timely manner, as VA is in the best position to coordinate their overall care beyond treatment for their substance use disorder, which is often just one aspect of their overall health care needs. Unfortunately, because VA has not developed a fee schedule for residential rehabilitation treatment, there's also no way to ensure that VA is not overpaying for these services. In fact, we've heard of some community residential treatment centers charging VA up to $6,000 a day for one veteran's care. It simply will not be sustainable for VA to continue paying for these services at these rates. I have said before, we must find a balance between community care and VA direct care. In my opinion, we have not found that balance when it comes to residential rehabilitation treatment facilities, and I look forward to hearing from our VA witnesses on how we can work together to get closer to that balance. I thank our witnesses for being here today, and with that, I will yield back.
Thank you, Ranking Member Brownlee. I would now like to introduce the panel one witnesses testifying before us today. We have Missy Jarrett, mother of Navy veteran Landon Holcomb, Mr. Michael Urban, Army veteran and licensed clinical social worker, and Dr. Shankar Yamachili, CEO of River Region Psychiatry. Ms. Jarrett, you're now recognized for 5 minutes to deliver your testimony.
Lord Meeks and Ranking Member Brownlee and all of the members attending today. I have Landon sitting right beside me, right here. And if you'll notice that infectious smile that I'm about to mention. If soldiers are going to die, it needs to be at the attempt of an enemy, not a lack of effort and unorganized antics by the VA. The VA is killing our soldiers. My son Landon, who served as an air traffic controller Navy veteran, NAS Jacksonville, 7 years ago, was struggling to find mental help in a system that completely failed him. Like many veterans, he reached out to the VA for help and support. His first consultation with a provider was on December 4th, 2023. However, the VA did not provide a follow-up visit until April 10th, 2024. Landon had scheduled events between this time frame. However, unfortunately, the VA canceled multiple visits, denying him the chance to see a provider who specialized in medicine management. Landon tried to keep his head up that the VA would follow through. He was experiencing anxiety, insomnia, restlessness, and mood swings. Landon knew that he needed a mood stabilizer. Mom, I'm struggling. After 4 unsuccessful months, he began to unravel with all of the canceled appointments. He became hopeless in the system. He was very emotional. On April 10th, he visited the Savannah VA mental health team, who determined that he wasn't under distress. How do you determine mental health when symptoms are invisible? Landon said the visit was a checklist, and he explained that he had been asking for a psychiatrist, medicine management. He was hoping for a better outcome and knew that this meant another delay in getting the help he critically needed. Those that smiled the brightest might be fighting a war within. Landon was fighting. He came by to see me after this visit. At this point, family and friends became involved in searching for a psychiatrist, and to no avail. We took it upon ourselves to call psychiatrists in the Savannah, Bluffton, and Hilton Head, South Carolina areas. They did not accept military insurance, take new patients, or charge $300 an hour. More stress. Landon made numerous calls himself.
Hey, Mom, I was calling you back. I was on my scooter. I messaged Jim. I tried to call Howard. I've also been on and off the phone with the therapy group, Shrink, Savannah, and the people over here at Coastal Empire. So been a lot of phone calls this morning. I'm going to get a workout in. Call me back when you want to. All right. Love you. Bye.
That call, that voicemail was the Monday before he died. On April 19th, he received a call from the Charleston VA for a Zoom appointment scheduled for May 3rd. He did not make that appointment and passed away on May 2nd. The unthinkable happened. Landon was found in the restroom of a restaurant on Hilton Head Island. He had fentanyl in his system. To numb his pain, he thought he was taking oxys. Landon did not plan to leave us. He was not suicidal. The hopelessness of canceled appointments, feeling abandoned and not taken seriously, and the emotional spiraling ended his life. Landon was buried at the Beaufort National Cemetery in South Carolina with U.S. Naval honors on May 13th. He leaves behind 2 beautiful teenagers, a loving family, and many loving friends. He was a true patriot who loved his country. Help just didn't come soon enough. Mental health is real. It can't wait. All Landon asked for was a mental health appointment for medicine management. He raised his hand over and over and over again. In memory of my 39-year-old son who could light up the room with his infectious smile, let his voice, be heard from heaven above, and on behalf of the veterans who struggle every day, let's be reminded to never leave a soldier behind. These are our children. This is why I'm here today. How many more testimonies is it going to take for change? How many? May God bless our military serving all over the world, and may God bless our veterans and all our military families.
Thank you very much, Ms. Jarrett. Mr. Urban, you're now recognized for 5 minutes to present your testimony.
Good afternoon, members of the committee. I'm honored to share my personal story and experiences with the Department of Veterans Affairs medical system. In 2003, after serving 4 years as a paratrooper in the 82nd Airborne, I was medically discharged following an accident during a jump. The subsequent 13 surgeries led to a regimen of heavy opioid use, a path all too familiar to many veterans. In 2004, I began receiving care at the Philadelphia VA Medical Center. In my journey, I've experienced firsthand the challenges of accessing care within the VA system. When I sought help in 2004, I faced a wait time of 2 to 3 months for a bed. I've had multiple stays in VA or RTPs where I witnessed practices that now as a clinician I know not to be best practices. In 2014, I had the opportunity to receive treatment outside the VA system, which provided a transformative experience. Since December 2nd, 2014, I have maintained sobriety and achieved numerous personal and professional milestones, all attributed to the quality of care I received. Community providers are required to operate following ASAM, a standard of care which is much higher than that of VA, a standard which I encourage VA to adopt. OIG has applied and referenced this standard during investigations into the deaths of veterans related to the lack of alcohol detoxification standards in 2021, 2022, 2023, and 2024. How many years, or yet better, how many more veterans must die before VA follows a standard? In 2020, during the pandemic, I developed a program for veterans affected by lockdowns, treating approximately 200 veterans from VISN 4 in under 6 months. This experience highlighted the potential for collaboration between VA and community providers, but also revealed inconsistent practices across different VA facilities. In 2021, I joined a national provider to develop veteran programming at 18 facilities, expanding my presence from local to national. This afforded me a unique glimpse of the entire VA system. Over the past 4 years, I have visited over 75 VAMCs, numerous CBOCs, and vet centers. I had the privilege to address VA service gaps not only at our 18 facilities, but by opening facilities in Alaska, Denver, virtual services for rural veterans, and develop an eating disorder program specifically for veterans. Through my extensive interactions with veterans, veteran advocates, and VA employees across the country, I have consistently encountered growing challenges in accessing community care for mental health. We have observed a decline in veterans' ability to receive this essential care, and this problem is not confined to a specific region. I have witnessed it in VA medical centers from Florida to Alaska. Unfortunately, the situation has deteriorated since last March. At Brockton VA, I worked with a veteran who was denied entry into RRTP due to past behavior. He then requested community care but was denied without reason. At Hines, a veteran was told drive time standards do not apply to his RRTP needs. In Houston, veterans were restricted to facilities only approved by the chief, limiting their choices. In Denver, veterans are all forced to travel out of state for VA care when it is available locally in the community. In Portland, VA, social workers confirmed, we don't use community care, referring veterans to Medicaid-accepting providers instead. In Philadelphia, veterans were denied community care due to the chief who told me, I can't send veterans to the community as it won't allow me to justify my budget next year. The issues faced by veterans in accessing community care are systemic and widespread. These challenges include VAs often fail to provide written explanations for denying community care, the interpretation of access standards, obtaining a consult and referral for substance use and mental health has become complex and time-consuming. Requests for services for veterans hospitalized in the community are not processed promptly, leading to prolonged delays and discharge without necessary care. And 5, ignoring the best medical interest standard. Administrators often prioritize VA interests over decisions made by the veteran and provider. I have personally witnessed the struggles of homeless and addicted veterans in almost every state. Many of them prefer not to seek care at the VA due to the barriers they face, instead opting for Medicaid or community resources. This raises a question: why should veterans who are entitled to VA services rely on Medicaid when VA is specifically funded to support them? VA has a tagline, choose VA. Well, I must tell you, it's not much of a choice when VA employees are the one making the choice. During the pandemic, we demonstrated the community and VA can effectively collaborate to address challenges faced by veterans. By working together, we can better tackle these issues and provide more comprehensive support. It has become an us versus them mentality, and the ones who suffer are my fellow veterans. Instead of creating barriers, VA should focus on removing them, particularly for those seeking mental health treatment. Each year, VA releases statistics on veteran suicide, which remains almost unchanged despite VA's significant investments in initiatives like increased outreach. While outreach is crucial, it is insufficient when a veteran in crisis is met with very limited options, such as being placed on an acute psych ward or the police. Being confined in such a setting can feel punitive rather than supportive for those seeking help. It is time for us to prioritize improving access to care and the appropriate levels of care from the moment a veteran requests it. Rather than subjecting them to a bureaucratic nightmare, or worse, a literal one, by doing so, we can ensure that veterans receive timely and effective support when they need it most. Whether it be at VA or in the community, we need timely access to care, and we only get there by working together.
Thank you, Mr. Urban. Dr. Yalamanchali, you're now recognized for 5 minutes to present your testimony.
Thank you. Good afternoon, Chairwoman Miller Meeks, Ranking Member Brownlee, and members of the subcommittee. Thank you for the opportunity to testify today. I'm honored and privileged to be here and serve our country. I'm here to be a resource to our country and our veterans and the VA. My name is Dr. Yalamanchali, though many know me as Dr. Chili, and I'm a board-certified psychiatrist with over 20 years of experience. I currently serve as the founder and medical director of River Region Psychiatry Associates, soon to be Ally Psychiatry, a multi-state behavioral health enterprise. Our mission is simple: to improve access to high-quality mental health care for those who need it most, close to where they live, while reducing costs and increasing efficiency. Our practice roots started in, and we continue to provide care in rural communities. As our future name suggests, we want to be an ally to everyone that seeks help. After beginning my psychiatric career in the VA hospitals of Montgomery and Tuskegee in 2005, I became increasingly frustrated with inefficiencies that prevented veterans from getting timely care. I later moved to community mental health centers where I worked to improve operations. However, I quickly saw how widespread financial mismanagement, systemic inefficiencies, and fragmented care delivery were contributing to the rising costs and poor outcomes, not only for patients, but for the healthcare system as a whole. Today, I stand before you to offer a proven, scalable solution that has already improved mental health access for thousands of patients, and one that has the potential to save our nation, I believe, at least $1 billion annually in healthcare costs. At RRP and Ally Psychiatry, we have built a care model that delivers patient-centered, technology-driven care across both inpatient and outpatient settings. In 2024 alone, our 68 physicians and 157 advanced practice providers served over 115,000 outpatients and completed over 400,000 patient visits. Our inpatient services are located in hospitals, jails, residential treatment centers, ensuring care is accessible across a variety of environments. With this expansive footprint, our model delivers care at approximately 25% lower per patient costs than the traditional VA or hospital systems. Moreover, we consistently outperform national benchmarks, achieving a 20% increase in emergency department throughput, 25% reduction in inpatient length of stay, and 15% reduction in avoidable readmissions for behavioral health patients. Our providers average 1,000 more patient encounters a year more than full-time employees at the VA, who often see 8 to 10 patients a day on a 4-day work week. With our care model, 100 RRPA providers working in the VA system could enable 100,000 more patient visits annually, while reducing costs up to 20 to 30%, which is what we have seen in our current partnerships. There are real challenges in access to care at the VA. Despite the best intentions of both providers and administrators, the 2023 GAO report found that veterans often wait 30 days or more for routine mental health appointments, even longer in rural areas where sometimes wait times exceed 60 days. Community care network meant to expand access, but it often fails to meet the needs of veterans with chronic mental health conditions, providing only episodic care with limited continuity. Many of these issues are due in part to staffing shortages. For example, the VA OIG report reported that over 61 facilities had severe psychology shortages and 47 facilities had severe psychiatry shortages in 2023. This means that the providers that are there often cannot handle the current caseloads, patients aren't seen in a timely manner, and providers suffer burnout. Delayed care, as we hear, can lead to worsening mental health conditions, high rates of hospitalizations, and increased emergency room use, all of which endanger patients' well-being and raise costs. The VA has a challenge to hire full-time psychiatrists, nurse practitioners, and physician assistants. They're competing with the private market and hospital systems. When needed, contracting with practices like mine would allow the VA to save on hiring, training, long-term benefit costs, infrastructure costs. It will enable the VA to scale staff based on need and have access to specialized expertise very quickly. And they could do all of this while enhancing patient access and care. There are numerous ways that the VA can do this. There are models that I have outlined in my written testimony. I believe that allowing increased public-private partnerships to address chronic care needs is a common sense first step, particularly as this is an area where the current community care network falls short. Under this model, for example, private partners would contract with the VA for services as needed when there are staffing issues, lag in patient wait times, or lack of VA resources. Private partners would be required to integrate with the VA's electronic medical records to ensure seamless information sharing and collaboration with VA teams. This allows for continuity of care, greater provider availability, and reduced wait times, especially for veterans in rural and underserved areas. Private practice such as mine have more flexibility to work with local clinics and provide greater telemedicine options. Therefore, we can eliminate typical access barriers and deliver most appropriate, cost-effective care. In emergencies, we can quickly get the veteran to the best level of care in a very short time. In closing, the VA needs support in closing access gaps and reducing wait times for mental health care. Our model at RP and Allied Psychiatry demonstrates that a partnership with private providers can expand capacity, improve patient outcomes, and reduce costs. This permanent public-private partnership model is a win-win for veterans, taxpayers, and our nation. Our success so far is based on a collaborative model to improve outcomes, and we ask for the same. Thank you.
Thank you, Dr. Yalamanchili. In accordance with Committee Rule 5E, I ask unanimous consent that Representative Carter from Georgia be permitted to participate in today's subcommittee hearing. Without objection, so ordered. As is my typical practice, I'll reserve my time until all other members have had a chance to ask their questions. I now recognize Ranking Member Brownlee for 5 minutes for any questions she may have.
Thank you, Madam Chair. Mr. Urban, since you mentioned having been employed by a national provider of substance use disorder treatment starting in February 2021, the majority of my questions, I think, are going to be towards you. So first, I believe the company you worked for starting in February of 2021 was Banyan Treatment Recovery, LLC. Is that correct?
Yes, ma'am.
Pardon me?
Yes, ma'am.
Thank you. In your written testimony, you mentioned VA having cut reimbursement rates to this provider by 90% for virtual care and by 60% for residential treatment and detox. What rates was Banyan charging VA daily?
Ma'am, I couldn't answer that because I wasn't in billing.
You weren't in the building?
Billing.
In the billing.
I don't take part in billing. I just build the programs and operate them.
So you have no idea how the VA's rates compare to other payers' rates?
I do. Their initial rates were, I don't know who set them, but they weren't educated.
They were not what?
They were not educated. The rate fee that I did see was far beyond what anybody should have been reimbursed, but that was VA's schedule. We had nothing to do with that.
Well, VA doesn't have a schedule.
They do, ma'am. I can forward it to you.
There's no established fee schedule for community providers in this kind of treatment.
Ma'am, there is one in Alaska because that's why we asked for a fee waiver that the VA just put out in 2020.
That might be the VA hospital in Alaska that does that, but not VA Central. But anyway, so I guess you don't know if your rates were higher, lower, about the same?
No, ma'am, I said originally when I first saw the rates, they were beyond what anybody should have been paying.
So you're saying you're paying a lot less, or charging a lot less?
Now they're more in line. No. What VA was reimbursing based on their fee schedule was beyond what any commercial insurance pays. The rates are now in line due to most of the rate cuts, but now they've went so far that rural veterans and veterans in Alaska, you can't sustain operations because they just cut them.
You seem to know a lot about the rates, but you don't know what Banyan was charging?
I'm not in that department. I
know, but you seem to know a lot about, where the rates were, where they are now, but yet don't have any idea what the number is.
I don't, ma'am, because what I'm told is these rates are getting cut, and if we don't figure this out, you won't sustain treating veterans. My job is to build programs and operate them. I get told the budget and whatever it is they set for that facility. I'm not in the internal billing.
Okay. I just, for the record, disagree. The VA does not have a fee schedule for community providers, period. Full stop. But in your bio, it says in your current role as a consultant that you develop business strategies and train teams on outreach to the veteran and military populations. Can you elaborate on exactly what that means?
Yes, ma'am. I train organizations who would like to work with veterans on veteran language, how the VA operates, how it functions, how to collaborate. We've created systems to collaborate effectively with the VA.
And develop business strategies? What does that look like?
That means teaching them how they can reach veterans in the community who need resources. So in Alaska, right, the villages where none of the VA employees will go, I trained a company to go to the villages and find veterans and bring them back.
Okay. Honestly, it sounds like to me that it says you're helping treatment facilities like the one you used to work for more effectively targeting veterans to receive care at the facilities you worked with, which also brings along a dedicated revenue stream in the form of VA reimbursements. Does a financial incentive to treat veterans exist in the facilities like Banyan?
I mean, it's a job. It would be the same as you worked at the VA. You have an interest in keeping veterans in the VA, so wouldn't you in the private sector?
I'm talking about incentives, about how many people you can bring into the facility, et cetera.
Not where I have worked, no, ma'am.
Okay. I will just say, I think, the providers in this industry seem to have, to me, a profit motive to serve veterans. VA's mission is to honor the promises we have made to our veterans and ethically care for their whole health after they serve our country. Their motivation is to provide world-class care to veterans. It's clear to me that through the actions of your past employers and your own actions as a consultant, that your motives are very different. And with that, I will yield back.
Thank you, Ranking Member Brownlee. The chair now recognizes Dr. Dexter for 5 minutes for any questions she may have.
Thank you, Madam Chair. First, thank you to our panel for coming. And Ms. Jarrett, I am so sorry for the loss of your son, and thank you for your courage coming to share his story with us. It means a great deal. Having taken care of many patients, unfortunately, like your son is a critical care doctor, what I can say for certain is he's not, unfortunately, alone, and we are failing not just our veterans, but everyone in our community across this country. This is a tragic reality that we are all facing. I also know, having been both a VA and a community provider, that community standard, as Mr. Urban talked about, is actually not superior in many areas to the Veterans Administration care. I know we're failing everyone broadly, but to be clear, what we don't know with these policies, and this is just for the record, we don't have any ability to compare when we refer someone whether or not they will get community care faster than they will get in the VA, or if it's better quality. And on that quality note, Mr. Urban, wanted to first thank you for your service to our country and for sharing your story as well with substance use disorder and your desire, which is clear, to help our veterans deal with that. I trust your intentions are good and that you share in this committee's commitment to ensuring our veterans receive the highest quality of care. But what I read in preparing for today's hearing, similar to what I think my ranking member were trying to get to, is that we are concerned about the reimbursement that does not have a fee schedule, and I know that different areas may have different policies, but that we are paying as much as $6,000 a day for inpatient care for some of this treatment. Mr. Urban, does that seem consistent with community levels of reimbursement in your experience?
Currently, or when they started? When
$6,000 a day reimbursement.
It's absolutely insane. I said that in my last statement. No one should be paying that amount of money.
I agree. And so I think what foundationally I would assert is that before we pass any such policy as this, we should have a fee schedule. We need to have control over what we are paying to the community, because there is waste, fraud, and abuse that is potentially going to be a risk with this without better control. We also should know how long it should take for someone to be expecting treatment if they're sent to the community, and whether it's sooner than in the VA. So those things I wanted to establish. I also understand that you weren't the manager, you weren't in charge of running these facilities necessarily. Is that correct, Mr. Urban?
Correct, ma'am.
Okay. There clearly were many issues at both Banyan Treatment and Recovery, as well as, is it correct that you worked at the Livengren Foundation in 2019 through 2021?
Yes, ma'am.
Okay. And also at Sobriety Solutions from June of 2018 to May of 2020?
Yes, they weren't community providers, though.
So none of those were providing?
Just Livengren.
Okay. Thank you for that clarification. The thing I wanted to offer is that there could be community care in different areas of the community, that may be a reflective experience, that these facilities each had improper safety, well, I'll say to Banyan, there were improper safety measures at one of their facilities that led to a permanent paralysis of a patient who fell from the 4th floor roof, that there were nurses who had wages that were revoked, that the New Jersey Commission of Investigation found that Banyan was engaged in patient brokering and the practice of paying for referrals. So I'm not asserting that this is your practice by any means, but what I do want to suggest is that there is incentive for waste, fraud, and abuse when we don't have clear expectations for community care and the quality of that care. And even when providers have the best interests, that you may not have control of that. Is that a fair assertion, Mr. Urban?
Yes, ma'am.
Thank you. So for the committee, what I wanted to establish is that even for someone who clearly cares for our wellness of our veteran, is a veteran, has suffered with substance use disorder, and wants to serve, it's challenging to maintain high levels of care. And our veterans deserve to have the highest quality, most effective care, and we know that that is provided within the Veterans Administration. And until we have a fee schedule that is established and disincentivizes waste, fraud, and abuse, I would assert that we should not be considering further exploration of expansion of this. Thank you.
The gentlewoman yields. The chair now recognizes Representative Carter for 5 minutes.
Thank you, Madam Chair, and thank you for holding this hearing. I appreciate this very much, and thank you for allowing me to wave on. I also want to thank the witnesses, particularly my constituent, Missy Jarrett. Missy, thank you for being here. Your courage is an inspiration to all of us, and I want you to know how much we appreciate this. I know this is not easy for you, and you've been up here, it's the second time you've been up here in, I think, less than a month. And we appreciate that very much. And I know that, I say I know, I can only imagine what it's like to lose a son. I can't even go there. But I want you to know that you've made a purpose of making sure that you're advocating for necessary changes and reforms to the VA that would raise awareness about the dangers of illicit fentanyl poisoning. As you know, I'm a pharmacist, and I'm very familiar with fentanyl, and I'm very familiar with the illicit use of it. But I want to tell you, Madam Chair, members of the committee, first class, as you heard, I'm sure, first class Landon Holcomb exemplified what it meant to be and to serve his country. He was born in Savannah, Georgia on April 22nd, 1985, and he was a proud veteran. And he was a patriot of this great nation. He served as an air traffic controller in Jacksonville, Florida. He was a father to 2 children. They're now teenagers. And he passed away on May 2nd, 2024, due to fentanyl poisoning. Poisoning. Not fentanyl addiction, fentanyl poisoning. He was a veteran who was experiencing mental health issues, like many of our veterans do, once they get out of the service. And like many of our veterans, he reached out to the VA, but unfortunately, the VA's response was not adequate, and it was unsuccessful at preventing the tragedy from occurring. Under the previous administration, the VA canceled multiple visits and denied Mr. Holcomb the chance to see a health care provider during a time of need. Ms. Jarrett, do you believe, had your son been able to receive care from qualified providers in the community without delay, do you believe it would have changed the outcome?
Yes. He would be with us today. What we experienced with him in the emotions, to the point where I let the committee hear his voicemail, which was Monday, prior to passing away on Thursday. He went to work Tuesday, went to work Wednesday, called Thursday morning to talk to his brother and myself, and who was vacationing from Colorado in Savannah. We all had plans. So after it was around 5:22 p.m., he walked into a restaurant, as I said, on the island. They found him 45 minutes later. They worked on him 20 minutes. And of course, the telephone call, received a call, and I will never forget it. you know, grieving, it's always going to be there. And I question as to whether I was going to come back up here. Thanks to Congresswoman Miller Meeks, I received an invitation to come back. So giving back, I guess I could call this, is a way for me to give back. Maybe in Landon's memory, veterans out there, like I said, are waiting. And I sit here and I listen. I sat through your previous meeting, and I sit here listening, go back and forth about what should be covered in benefits under the VA. And I'm thinking, why is this even an issue? In the private health sector, under private plans, we cover bariatrics. We cover the therapy you're talking about, and you're still talking about it. Preventive care's been there, 100% down the line. We even covered vitamins in our plan. Preventive care is all about providing those tools and resources to keep people healthy. And that includes veterans and their dependents as well. So I'm like, therapy. And then in 2019, under the Trump administration, he passed the right to try. Yet you're sitting here talking about, are we going to cover this or that? Well, a veteran has the same right as we do to try psychedelics, to try cancer treatments, to try therapy programs. If I'm wrong, let me know, but in my mind I was thinking, right to try's out there. Why is it a question? Why can't they do it if they want to do it? And they make that decision as to whether they want to have it or not based on whatever they know. So under the VA, I can't imagine, I just realized you're talking about there's not a fee schedule. How do you operate without a fee schedule? I mean, networks operate, doctors operate with fee schedules. And when you're in a network, the whole reason you have a network is because doctors are looking for you to steer patients to them, which reduces fees also. So a network, okay, there's networks out there. You have the community care group. And by the way, when I went to our zip code in Savannah, here's your VA website, va.gov, and you can go across and you can review benefits, resources, tools, mental health. I went to the mental health site and I typed in, you can search a provider by zip code or city. So I typed in our zip code in Savannah, Georgia, the facility type, which is required. It comes up, community providers in VA's network. Service type required, so you can type in chiropractic or optometrist. I typed in psychiatrist. It pulled up. We couldn't find that. Please try another service.
Ms.
So
Jarrett, I'm sorry, we've already gone
ahead.
over, and the chair has been very
Yeah.
indulgent. But again, I want to thank you for being here, and I want to thank you for your courage and for your advocacy. You've made it your purpose to bring this to attention to all of us, and we appreciate that very much, and God bless you.
Thank you, Congressman. I appreciate it.
Absolutely.
Thank you,
I
the
yield back, and
invitation.
thank you for your indulgence, all the committee.
The gentleman yields. Thank you very much, Representative Carter. Ms. Jarrett, thank you for your bravery in being here. I guess I just have a very simple question. Did your son was denied and delayed numerous appointments?
Right.
The initial appointments were months apart when he received one visit. Did anyone at the VA ever explain your family's right to access community care or offer you alternative treatment options when VA programs were unavailable?
To my knowledge, no.
Yeah. And, you know, we've heard today that, you know, veterans should have the highest quality, most effective care. Do you think that your son, through the VA, had the highest quality, most effective care?
Congresswoman Landon lived in Colorado, so he accessed the VA in Colorado. There was not a problem there. He said, Mom, it stayed there. He lived in Nashville, North Carolina. He was pleased with the facility there, okay, the VA there. As a matter of fact, he made a comment. He said, Mom, if I were back in Asheville, you know, I would have gotten in sooner. Okay, he moved south to be near family, his daughter, etc. So what I'm saying is what he saw, there are inconsistencies between the centers and there's not coordination of care.
Yeah, precisely, which is why we have
Right.
community care, because of the inconsistencies and lack of care. Do you believe that no care is better than care in the community? Mr. Urban, is no care better than care in the community?
Absolutely not.
Dr. Chili, is no care better than care in the community?
No, ma'am.
Yeah, and how cost-effective is it if people die waiting for care at the VA? Dr. Chili, you noted that practices like yours achieve significant cost savings, up to 30%, while expanding patient capacity. It doesn't sound like you're driven by a profit motive to me. Can you provide more detail on how these savings are realized without compromising care quality, particularly within the VA system's regulatory framework?
One of our philosophies is that we went to school with the community at large, actually, families and universities have given us a unique skill to treat patients. With that, we kind of, in the group anyway, we think that how many people can we reach? How many people can we touch? How many people can we help? So in that model, we set up our schedules in such a way that there's gradients in schedule where new patients require more time, patients in crisis require more time, patients that are midway to the treatment may require a little bit less, patients that are stable, they require less. We collaborate between the providers and the therapists to see how things are flowing and either getting better or worse. If patients need to come back sooner, we bring them back in sooner. If we need to see them more frequently, we see them more frequently. So with this kind of a matrix of how we see patients, I think we're able to see more patients in a given day, but at the end of the day, it's the same cost, right? So then when you look at how much is, let's say if we're spending whatever amount of money, but then we're seeing more patients, then your per patient cost comes down.
Thank you. And Mr. Urban, given your story and both your written and your verbal testimony, it seems to me like your experience at the VA, or lack of care, inconsistent care, difficulty at accessing care, is really what propelled you into the profession you now hold. And based upon your experience, what's the single most consequential policy failure that prevents veterans from receiving timely residential substance use disorder treatment through the VA?
I think the time it gets access to care, if you read VHA Directive 1601, it says, you have 7 days to complete a screening from when someone asks for help. 7 days, good luck. You know how long it took me to get to those 7 days before I finally was offered a bed 2 months away? I mean, I think the access to care and how long it takes to get care and the different schemes, the different ways VAs have set up the process delays care. And every VA is different in the way they want you to get a mental health referral to treatment, that people just give up. They just say, oh, I don't care, I'll go to Medicaid, or I'll use a community resource, as opposed to getting timely access. I'm not opposed to getting care at the VA, but it shouldn't take a month, 2 months, and as far as standards, we can't compare apples to apples when VA makes its own standard, and ASAM is what the industry follows.
Well, let me address that. What clinical standards, such as ASAM criteria, do you believe the VA should be required to adopt nationally to ensure consistent levels of care for substance use disorder treatment? And if, Dr. Chili, you have input, please provide that as well.
I think it should be utilizing ASAM because it dictates the level of care someone should get at. It dictates the intensity of care. It dictates the services, the staffing ratios. It lays everything out and places someone appropriately, as opposed to this, well, we have a bed in the acute psych ward, we'll put you there till an RRT, that's the difference.
And if I can allow you to redeem yourself, and I know I'm going over time, so Mr. Urban, is what drives you to do what you do profit?
No, ma'am, I don't want someone waiting 2 to 3 months for a bed.
And Dr. Chili, given what you do and the model you've created, is profit the reason why you do what you do?
No, ma'am.
Thank you very much. On behalf of the subcommittee, I want to thank you all for your testimony and for joining us today. You are now excused. We'll wait for a moment while the second panel comes to the table. I would now like to introduce the panel to witnesses testifying before us today. Dr. Maria D. Laurenti, Acting Assistant Undersecretary for Health for Integrated Veterans Care at the Veterans Health Administration, who's accompanied by Dr. Ilse Weikers, Deputy Director, Office of Mental Health at the Veterans Health Administration. If I mispronounced your name, please feel free to correct me. Dr. Laurenti, you're now recognized for 5 minutes to deliver your opening statement.
Before I start my oral testimony, I just want to acknowledge and thank the first panel for sharing their very personal stories, particularly one of such devastating loss. It really does take a lot of courage, and I want to thank them for advocating for other veterans. Chairwoman Miller Meeks, Ranking Member Brownlee, and other members of the subcommittee. My name is Maria Laurenti, and I was recently appointed as the Acting Assistant Undersecretary for Health for Integrated Veteran Care. It's been my privilege to work as a VA psychiatrist, being board certified in adult and geriatric psychiatry and addiction medicine for the past 30 years. I take care of veterans with mental health and substance use disorders, and it's an honor to serve veterans who've made such significant sacrifices for our country. Thank you for the opportunity today to discuss the provision of residential substance use disorder, or SUD, treatment through VA's mental health residential rehabilitation treatment programs, or MHRRTP, and community care residential treatment programs. Joining me here today is Dr. Ilse Weikers, Deputy Director, Office of Mental Health, Veterans Health Administration, and also a geriatric psychiatrist and provider. Prior to the Mission Act, in one of my prior roles as the Associate Chief of Staff for Mental Health at a VA medical center, I experienced firsthand the challenges our veterans faced related to access for residential treatment programs. The facility where I worked didn't have its own residential treatment program, so we had to refer veterans to other facilities that did. The demand for this life-saving care often exceeded the supply of available beds, and this delay in care increased the risk of relapse and worse health outcomes. Offering our veterans access to residential treatment through community care addressed this concern. This allowed us to seamlessly transition the veteran into residential care when indicated. Timely access to residential treatment programs enhances overall outcomes, so that the veteran was more likely to engage in mental health services and treatment and maintain sobriety. MHRRTPs provide care within specialized SUD programs, referred to as domiciliary SUD programs, as well as across the full MHRRTP continuum, which includes programs for the treatment of post-traumatic stress disorder, general mental health concerns, and services for homeless veterans. These programs have evolved over time to better meet the needs of veterans. For example, in 2012, as part of the first Culture of Safety stand-down, VA introduced naloxone as a critical tool to prevent overdose deaths. The passage of the VA Mission Act of 2018 expanded access to community care, furthering transforming veteran care. This law expanded access to eligible veterans who can elect to receive care in the community in certain situations. In October 2020, VA developed the MHRRTP standardized episode of care, which made it easier for VA to order residential treatment in the community. This has led to significant growth in the number of community programs providing residential treatment and the number of veterans receiving this care. To help maintain high-quality care for veterans, VA requires that residential community care providers maintain appropriate credentials, such as by the Commission on Accreditation of Rehabilitation Facilities or by the Joint Commission. As of March 2025, there are over 260 MHRRTPs across 125 locations, providing more than 6,600 operational beds. In FY24, approximately 32,000 veterans used MHRRTP care, with 97% diagnosed with SUD and over 92% with co-occurring SUD and mental health diagnoses. And during the first quarter of the current fiscal year, 70% of veterans were admitted to VA domiciliary care within 20 days. Increasing access to community care is a significant component of VA's strategy to ensure that veterans have access to the care they need. And on average, veterans must travel 150 minutes or more to receive this specialized care, whether through VA or through community care. For VA to continue to meet the growing need for MHR RTP care, we acknowledge that changes are needed to VA's current access standards. As a result, VA was proud to support the Veterans Access Act of 2025 before the full House Committee on Veterans Affairs on February 25th, 2025, while ensuring the offsets or additional appropriations are provided. We're committed to working with Congress and our other stakeholders to reduce barriers and improve access to the care veterans have earned. We want to thank the committee for its continued oversight, and we would be happy to answer any questions you or other members of the subcommittee may have. Thank you.
Thank you, Dr. Laurenti. As my typical practice, I'll reserve my time until all of the other members have had a chance to ask their questions. I now recognize Ranking Member Brownlee for 5 minutes for any questions she may have.
Thank you, Madam Chair. Dr. Wiekers, can you tell me how many mental health providers have resigned or retired earlier than expected since January 20th, 2025?
I don't have those numbers in front of me for the national set of numbers. No, I don't.
So you know how many, you just
No.
don't have that
I do
information
not-
with you?
I do not have that number. It's not under the purview of my office.
And whose purview is it?
It would be an information that we would have at a facility and a VISN level. So I would have to dig in to get those numbers for you. I don't have those numbers
Okay.
available to me.
And
in my office.
I presume by your answer that the mental health providers who accepted the so-called fork in the road offer, you have the same answer for that as well? You don't know the numbers and it's not under your purview?
Correct.
Okay. Dr. Laurenti, as you probably gathered from my questioning in the first panel, I am very concerned that VA has not developed a fee schedule for residential treatment facilities, and you are currently reimbursing these providers at much higher rates than industry norms. On average, VA has been paying $3,000 per day for this type of care. Some providers are getting paid as much as $6,000 a day, far more than the average cost of care per day in an ICU. I understand that the VA has been working for some time to establish this fee schedule and bring its payment rates more in line with industry norms. I also understand that VA will have to modify its contracts, both with TriWest and Optum, in order to implement a new fee schedule. So can you tell me what the status of this effort is? And when you'll have a fee schedule in place?
Yes, ma'am. I'm very appreciative, actually, that you asked those questions. It's my understanding that in December, this past December, TriWest did establish a policy with respect to reimbursements for our RTPs that are within their network. I believe that that was in part what the first panelist was referencing. Because those payments are now a per diem rather than multiple line items, it did make differences with respect to the providers in that network. In addition to that, with respect to IOPs and PHPs, those fees are now in keeping with CMS standards. With respect to Optum, I would have to take that question back in order to provide you with a more accurate status update.
So if I understand you correctly, you're saying that the schedule that the previous witness was referring to was possibly a schedule that was my understanding is that it might be a percentage of a cost that is charged, or a percentage of what the rate would be, rather than here's the rate for this specific, for an hour of care, or for this specific care. It's not explicit and sort of complete for everything that possibly these residential providers would provide.
My understanding is it's a per diem, as opposed to multiple billings, but I can get you the details, ma'am.
So are residential treatment providers qualified to provide emergency stabilization care for veterans experiencing an acute suicidal crisis under the authority provided by the Compact Act?
It would have to depend upon the residential facility itself. So standalone residential treatment programs, no. If the residential treatment program is part of a healthcare system that includes an emergency department with 24/7 coverage, then it could.
So for standalone providers that don't have hospitals or emergency care, the answer is no, correct?
That's my understanding, yes.
So is it true that VA has detected a pattern of certain community providers admitting veterans for residential rehabilitation treatment without VA authorization and then attempting to build VA for this care under the Compact Act?
I personally don't have detailed information of what you're referencing, but I'm more than happy to inquire and get the information back to you.
I will just say that your predecessor told both the House and Senate committee staff that that was occurring.
And that's entirely possible, ma'am. I just don't have firsthand knowledge.
So the Office of Inspector General also issued this fraud alert in December of 2024, requesting the public's help in stopping scams involving substance use disorder treatments. Specifically, the OIG warned, quote, certain drug and alcohol rehabilitation facilities or treatment centers are attempting to exploit veterans with substance use disorders for profit through various unethical and illegal practices. So do you know what the VA is doing to remove bad actors like these from the community care program?
Yes, ma'am. Several different things. The first is when we do identify concerns with respect to those types of practices, we often will reach out to the IG, request an investigation, describe the nature of the concerns that we've identified, and at the same time, we will also notify the TPA if that particular provider is in one of our networks. Based on my understanding of how the contracts work, the TPA then will conduct an investigation. Based on the results of those investigations, then there's typically a back and forth with the VA. When findings are substantiated, then those types of providers could be removed from our network.
It's my understanding that the OIG is still investigating some of these issues, so you might get some results in the near future. I yield back.
And thank you, Ranking Member Brownlee. The chair now recognizes Dr. Dexter for 5 minutes.
Thank you so much, Madam Chair. And thank you again to our panel for being here. I share my Republican colleagues' concerns about the veterans' access to care and the wait times they are facing for mental health care, substance use disorder treatment, and residential rehabilitation treatment programs. But as I shared previously, this is not a specific problem to our Veterans Administration facilities. This is a community-wide problem. In fact, in my district, we continue to have far too few care providers and far too long of delays, and that's not improving, it's getting worse. So I think it feels like magical thinking when we offer proposals to codify additional community care access standards when it's abundantly clear that there is not the capacity in the community to accept our veterans and get them the urgent care that they need. So I'll just state that I believe in controlling the controllables. We can't control outside of the VA, but we can control what we are doing within the VA. And as Ranking Member Brownlee pointed out earlier, the VA does not have a set fee schedule, so that needs to be changed. Clearly, paying $6,000 a day is egregious and a waste of taxpayer dollars. But I also think it's not exactly shocking that while referrals to inpatient care, including residential treatment, made up about 13% of the VA's total behavioral health referrals to community care providers in fiscal year 2021 through 2023, those referrals, that 13%, made up nearly 3/4 of the total expenditures for behavioral community care referrals. So we have a problem. I think we can agree on that. And I'll just state for the record that Dr. Lauren is
Yes, ma'am.
yes,
Agreed.
nodding her head. So I'll just ask you, do you also agree that we should be seeking to ensure that veterans are getting proven high-quality care in all instances as much as possible?
Yes, ma'am. There's no question about that. I mean, veterans deserve the very best care. And we're very proud that we are able to demonstrate with studies, research, that VA delivers that care. But unfortunately, not every VA has that care available, and that's where community care can fill a gap.
Exactly, and I absolutely agree that we need to make sure that they have that care. I think accreditation requirements into community care contracts is important. For instance, there's this mind-blowing case in South Florida of a community care provider that employed patient recruiters to give illegal drugs prior to admission to ensure that patients were admitted for detox services, which were the most expensive. Obviously, none of us want our taxpayer dollars used at the doing harm to our veterans. So community care standards, fee schedule, and I also just wanted to ask Dr. Laurent, can you confirm that in late January, President Trump fired the VA's Inspector General, Michael Missel?
That's what I read in the news, yes, ma'am.
Yeah, and we've been talking about the Inspector General's office and the importance that they play in investigating some of these things. Would you agree that not having an Inspector General impedes our ability to do that?
So I don't know that I can fully agree with that, because we continue to engage with the Inspector General's office. We continue to participate in investigation inquiries, in audits. We receive reports and findings, and really engage very, very collaboratively with the Inspector General's office. That work has continued.
I am so happy to hear that it's continuing, and I think it's probably a short-term reality that until there's some upper-level director, in my experience, when there's no captain, things kind of derail over time. So that's not a question. I don't need you. You don't have to make a position on that. But I just want to bring us back to acknowledging that the larger context that we are all here to do is make sure our veterans are getting the best care possible. Our administration has fired veterans staff. It has removed the Inspector General. We are here talking about spending less money in our budgets for the veterans, and we are wasting a lot of that on unnecessary expenditures that we have the ability to control. So I just hope before this committee sends anything to the floor that my colleagues and I can work together to address this head-on and ensure the administration is allowing us to inspect things, but also that we are making sure that our veterans have access to the best possible care and that our policies reflect that. Thank you, Madam Chair. I yield back.
Thank you, Dr. Dexter. The chair now recognizes Dr. Morrison for 5 minutes for any questions you may have.
Thank you, Madam Chair. I appreciate the discussion brought forward in this hearing about the importance of access to treatment for substance use disorders. It's imperative that that the care we offer our veterans comes from providers with a demonstrated ability to deliver high-quality, evidence-based care. My experience as one of the millions of physicians that has trained in a VA facility gave me a firsthand introduction to the uniquely specialized care that the VA is able to offer our veterans. Achieving the goal of quality while preserving the specialized care VA offers requires intentional investment in VHA facilities that provide substance use disorder care and continual reflection on how providers are meeting veteran needs. For over 150 years, VA has been committed to providing residential care for veterans in need of additional structure and support. In 2022, VHA served over 300,000 veterans with substance use disorder diagnoses. Thank you, doctors, both of you, for being here today. In the spirit of understanding the progress VA has made in substance use disorder treatment, I have a couple of pretty straightforward questions for you, and they really are just yes or no questions. The first one is, has utilization of residential substance use disorder treatment programs increased over time?
And just to clarify, in direct care, community care, both?
Both.
Short answer is yes.
Would you agree, Doctor?
Absolutely, yes.
Okay, thank you. The next question is, has increased capacity in VA's substance use disorder treatment programs led to improvements in your ability to provide the intensive medical treatment veterans, especially underserved groups, increasingly need?
I'd like to ask Dr. Wiekers to answer that question.
Sure, yes or no?
Yes.
Okay, thank you. And then last question, would you characterize the educational training and staffing level requirements within VA's substance use disorder treatment programs to be consistent across your program sites?
Yes.
Okay, thank you very much. VA's commitment to developing a cohesive continuum of care is indispensable to achieving successful outcomes for veterans that find themselves at various stages of treatment for substance use disorders. I urge my colleagues to recognize the importance of supporting the residential substance use disorder treatment infrastructure within VHA, investing in expanded VA program capacity, and standing against tactics that would undercut treating our veterans with the dignity they so rightfully deserve. Thank you, Madam Chair. I yield back.
Thank you. The chair now recognizes herself for 5 minutes, and I would also urge my colleagues to recognize the care that comes in the community. The reason why a Mission Act exists is because patients weren't getting care. Veterans weren't getting care. They weren't getting access. They were waiting. They were dying. They were committing suicide. They're overdosing. They're dying of fentanyl poisoning. As a matter of fact, in this very hearing room, when we had a hearing on residential care and substance use disorder, prior VA officials admitted that they did not think that residential care or substance use disorder residential care fell under the Mission Act. So it didn't matter if the patient waited 30 days or 100 days or a year, they still weren't going to refer them to community care because they didn't feel it was under, that fell under the Mission Act. This is the VA's own words. Dr. Rente, and I'm an ophthalmologist. And not only have I worked at VA facilities, not only was my uncle, 6 of the 8 kids in my family are veterans. My father is, my husband is, my grandfathers are. My uncle was in a residential facility at the VA for his entire life when his ship went down the Pacific in World War II. And I've done substance use disorder and helped to change policies at the state level. But when a veteran is assessed as needing urgent residential care, how long do you think they should wait? And are you confident that every VA facility applies the same timeline and criteria to get that veteran placed or referred to the community without delay?
Thank you very much for that question. So first, let me say that the national policy is very clear and is applicable across the country. The fact that there is variability and a lack of standardization is a problem. There is no question about that.
If the standard is present, then that means the culture is not permitting the standard to be met. So because the committee continues to hear that policies governing residential treatment and community care referrals are interpreted differently depending on where a veteran seeks care, how is the VA going to ensure that policies are followed uniformly?
Thank you very much. The Secretary has initiated a review.
This would be Secretary Collins?
Yes, ma'am. Has initiated a review of policies, directives, staffing, organization, structure of multiple aspects of the direct care system, as well as multiple aspects of the community care system, in order to be able to begin to answer the questions that you're asking. In general, and these are generalities, when you have policy and it's just not being carried out, there are common reasons for that. Some common reasons is that the policy may not be clearly written. The policy may have broad, subject to interpretation features. It may be that we've simply not adequately trained the frontline staff. And there are a host of other reasons in between those things. Those are the things that we need to address because those are interfering with our ability to provide the access that the veterans need to have. It's creating barriers, and in some cases, it may be creating additional administrative steps.
And Dr. Rente, as I mentioned, we have programs like the Gordon Fox Parker Suicide Prevention Grant Program. We have buddy systems within our veteran service organizations that help veterans to navigate some of these things. And I realize that you're a recent addition, although you've cared and done mental health and substance use for a long time, but how do programs like the Gordon Parker Fox Suicide Prevention Grant Program help veterans access mental health care services?
Is that a question you might be able to take, Dr. Wiekers?
Sure. So the Fox Grants program provides grants to community organizations that are helping to engage veterans that don't engage directly with our VA health system. So it really helps to fill that gap in providing access out in the community. There are partners out in the community in helping engage veterans to reduce their risk for suicide. They can also, grantee participants can also access care through VA when they've become a part of one of the programs with a grantee.
So let me just say that, I think that our VA healthcare system, although I don't utilize it as a veteran, nor does my husband, I want to save that for the veterans who have most in need and need that access to care. But nonetheless, I think our, Veterans Administration, our hospitals, our programs do a very good job, but they're not always there. And it is those gaps that we're trying to fill, and these partnerships, whether they be in the private sector, in other avenues, that we're trying to make sure veterans have access to care. I think we all want the same thing, but I think to continually denigrate a provider that's outside the VA, just like to continually denigrate the VA itself, both of those attitudes are inappropriate and wrong, because as we've already said, we want the highest quality, most effective care. And sometimes that's at the VA hospital, and sometimes that's in the community, because if you can't get access to care, it doesn't matter how high the quality is, it doesn't matter how effective the program is. If you can't get access to care, you have no care. And given that I'm in a rural area, our veterans like to have access to care when and where they can get it. So with that, Ranking Member Brownlee, would you like to make any closing remarks? Would you like to make any closing remarks?
I would indeed. Thank you very much. So I'd just like to say that I agree with my colleagues across the aisle that we must ensure that any veteran who is ready to seek assistance can be treated unequivocally. I'm worried that treatment will not be available with the clinicians who have been either fired or can't be recruited. We're already understaffed. We need a fee schedule so that community providers will conform to industry norms. And we need to weed out bad actors and not fire very capable employees within the VA. And for the record, one more time, I will say I support community care, and community care is a critical partner to VA, but we've got to get it right. And I will yield back.
Thank you very much. I'm going to again remind this committee, as we did several weeks ago, that over the 4 years of the previous administration, there was an increase of $126 billion to the VA, an increase of 80,000 employees, 57 of those full-time, 23,000 part-time, and that, as we've heard from Secretary Collins, healthcare workers were exempt. With that, I'd like to thank everyone for their participation in today's hearing and for the great discussions we've had on this important topic. I'd especially like to thank our witnesses and Ms. Jarrett for her very moving testimony today and for having the courage to come forward. I want to thank both of our witnesses from the VA, some of whom may be new to this process, for being here today as well. Today's hearing reinforced what we've heard time and time again. While there may be very good care to excellent care at the VA, veterans don't struggle because the VA lacks funding or resources. They struggle because they continue to fall through the cracks of a bureaucratic system that's bogged down in inefficient processes and inconsistent standards. Veterans in crisis cannot afford to wait. I know this firsthand and personally. And I look forward to working with Secretary Collins and the VA to break down barriers preventing our veterans from accessing the life-saving care that they so desperately need in their moments of crisis, be it at a VA or be it in a community. The complete written statements of today's witnesses will be entered into the hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objection, so ordered. I thank the members and the witnesses for their attendance and participation today. This hearing is adjourned.